Hi, and welcome to the practice exam for Module 6 through 8, which is ankle, knee, hip, thigh, and pelvis. So how this will work is that the slides will have a simple picture, image, and then I will talk about it. On that image, there will be dots. Those dots are the practice exam questions. I recommend that you immediately click on those to test whether you know it or not, and then you allow the video to play, and I will explain it and review that content. If I still don't explain it in a way that you understand it, then you should go back to that module and look up that information and watch the video. The videos I'm going to make today are just brief versions of the videos I made in the modules, and those have better models that move and have ligaments. The models I'm using today are very brief, and most of them do not move. So if I'm confusing you at all, please go back through the modules. Please know that I don't know who's taking this. I can just see how many views, so I won't know what your grade is or how you're scoring. So feel free. There's no pressure, but I would try to test yourself so you really know if you're ready or not. So, moving on to the first thing, we're going to go over bony anatomy, and then we're going to do soft tissue anatomy, and then we're going to do key injury areas in each of those joints. So we'll start with the foot and ankle, and I would just encourage you to do the foot and ankle. That it just depends on like the view that you're looking at. Bones can look very different, so make sure you're not memorizing one specific image, but that you can like do Google images and you can identify it on lots of different images. So for example, when you're looking at the calcaneus and the talus on the hind foot here, you can see the image on the slide that has the posterior view. And you have the calcaneus on the bottom, and then right above it is the talus, and then you have the tibia. It's important to be able to identify that because the talus looks like a rhomboid there. But then when you look at it from the side, it's a very funky shaped bone. So you need to make sure that you understand that the shapes of these bones can look different in different views. So let's start with the toe bones. Toe bones or phalanges, the foot bones here that lead down. So we're talking first through fifth on the toe bone phalanges, and then also the foot bone, the metatarsals, 1 through 5. So we got metatarsals are the foot bones, phalanges are the toe bones. Then the tarsals are these irregular shaped bones that make up the midfoot here, and then also the hind foot with the calcaneus and the talus. And then when we're looking at the ankle, when you look down at your ankle bone, you'll see a bone sticking out here and a bone sticking out here. This is our lateral malleolus. It's a bony prominence on our distal fibula. So the distal fibula runs all the way up to the knee, or the fibula runs all the way up to the knee. The distal fibula is the end of it by the foot that makes up the lateral malleolus. The distal end of the tibia makes up the medial malleolus. These are really important attachment sites for our ligaments, our ankle ligaments, which we'll talk about in a second. One more thing that I want to touch on with the bones are the two joints in the ankle. We have talocrural, which is tibia to the talus. So this joint right here does plantar flexion. So this can't move. So I'm just moving the whole thing. But plantar flexion is when the foot goes down toward the ground like you're planting. And then dorsiflexion is going up. That's the talocrural joint between the tibia and the talus. Underneath that, between the calcaneus and the talus, is our subtalar. So sub is under our talus, and that is inversion moving in and then eversion moving out. So just know that those motions come from those different joints. Then when we start talking about ankle ligaments, when we talk about a medial ankle sprain versus a lateral ankle sprain, medial ankle sprains are less likely to happen because I have this tape here to act as the deltoid ligament. So this is a big, thick ligament that attaches from the medial malleolus down to the calcaneus. So this is our deltoid ligament, attaches all in here, actually, lots of attachments. And it is hard to sprain because you have your fibula on the outside that prevents it from really everting. So this prevents eversion where the foot kind of goes out. The lateral ankle sprain out here is 3 ligaments, and this is where a lot of our injuries, the most common injury spots. So we have our CFL, which is our calcaneofibular. So it's always telling you where they're attaching from the calcaneus to the fibula. Our anterior and our posterior talofibular ligaments. Talofibular are our lateral ankle sprain ligaments, and I'm making an emphasis on talo because it's coming from the talus to the fibula. So our anterior is the one that's most commonly injured, and it's very similar to this ligament up here, which is our high ankle sprain ligament, which is tibiofibular. So make sure you're paying attention to that difference. There will be questions about this. Tibiofibular, which is tibia to fibula, which is higher. Think about where it's located. The tibia and the fibula are more superior. They're higher. They're proximal to that talus that is really low. So talofibular, anterior talofibular ligament is our classic lateral ankle sprain ligament that gets injured all the time. And that is from inversion. So inversion and plantar flexion. So if we step on a curve, off a curb weird, and we go in like this, that's how we sprain that ligament. The high ankle sprain doesn't happen as commonly as the lateral ankle sprain, and it happens more in high energy sports like football. And that is from the opposite. So dorsiflexion with eversion, where it's really stressing, it's really pushing that tibia and fibula to split. And that is what that tibiofibular ligament does. So just make sure you know the difference, because those there's a lot of emphasis on that to understand those differences. Also, when you're looking at these muscles, one thing I want you to take home, there's a lot of muscles here, but I want you to take home the front, the anterior of the shin that goes out to the foot. These are extensors. It's extending our foot, extending our toes, pulling them up toward the body. On the posterior of the calf running down this way and under the foot are flexors. They're going to be curling our toes and then pulling our foot down. So just make sure you understand the anterior muscles are extensors, the posterior muscles are flexors. And that is a little different when we start comparing it to like the hip muscles. So make sure you have that written down and you understand. So we're talking about areas of high impact in the foot and common injury points. So let's just talk about acute versus chronic. If you get bogged down on these questions where it's asking you, look for clues. So if it's asking for like a chronic type injury, understand the difference between acute and chronic. So in a foot, right, something that is having a lot of repetitive weight-bearing movements, there's going to be a lot of chronic injuries, because chronic means it's been happening over time and it's repetitive. So if you see words like repetitive, you know that it's chronic. That's going to lead to things that may end in itis, like capsulitis, because itis is inflammation. If you see things like fractures or ruptures or tears, technically tears can be both, but usually tears, ruptures, things, that's all acute. So that's from like a one-time big high energy injury. So let's go to the toe. The big toe here, great toe, turf toe is a common injury here, because all of our weight, when we push off, it's all going through this toe. So there's a lot of force right here. So if the injury is asking, it's from this person's having a lot of repetitive movement here and they're getting some pain over time. What injury could it be? It's going to be something chronic like capsulitis. So the capsule here is being stretched out and it's angry. But if it was a one time, they landed on it really hard and they felt a pop or something, that's acute, and that would be the volar plate injury. So underneath, in the modules, I talked about how there's a piece of cartilage here and it's attached to the tendon and it pulls off and it ruptures. That's surgery. That's serious. If it doesn't get surgery, the career is ended. It's a big deal. You can't overlook that. Where capsulitis, you ice it, rest it, and get back. So very different. It's all about how the injury happened, the timeline of that. Some other injuries here, when we talk about the midfoot, a lot of stress goes through that great toe, but then also through this Liz Frank injury area. So you can have an acute one where you land kind of like this. A lot of pressure goes through here and it fractures or it separates and has a very severe sprain that also needs surgery. Or you just have chronic, like in people that are in military, they march a lot. So a lot of force goes through and you get stress fractures in the metatarsals and then into the midfoot and kind of this whole area. When we talk about acute fractures in the foot, something that a high energy force, something one time, that is usually on the lateral foot, and it's usually from that same mechanism that caused the lateral ankle sprains, where we like step wrong with our plantar flexion and we invert and our whole ankle kind of turns inward. When that happens, our fibula and our base of the fifth right here are the spots that are right here are the spots that are likely going to hit the ground or have a lot of force and fracture. So, or this ligament here will pull on the fibula and pull it off and fracture. So fibula fracture and base of the fifth fracture are common acute fractures in the foot. All right. We're going to move on to our knee anatomy. So when we're talking about our knee, the big thing here is to make sure you know the difference between the condyles and the tibial plateau. So when we're looking here at this is the tibia, and then this is the femur. The femoral condyles up here, these are the big bony landmarks here on the end of the bone, and they're nice. You can see how they're shaped, and they're shaped because the knee does a lot of flexion, right? So when we're bending and we're doing a deep squat versus when we're straight up, they have to land on this tibia plateau. Tibia plateau is just like basically a cliff. It has to be super strong. All the force of our body is going through this tibia plateau. There is more force going to the medial side than the lateral side. That is very important to know and emphasize. So there are a lot of injuries that kind of happen in that area. So in between, we have our meniscus. So it's important to know. Also, when you're orienting yourself with what is the lateral femoral condyle or the lateral tibial plateau versus the medial, find the fibula. My model here does not have a fibula, but if you look on the image, find where that fibula is, and then that is your lateral side. That's how I orient myself, and that is how you should do it too. So make sure you're doing that when it says find the lateral femoral condyle. Find where the fibula is, and then go to that side and click on this is the condyle. So your condyles are the ends of these bones here, these big like knob type of areas. All right, and then with the meniscus sits on this tibia plateau here, and they're cushions. Fibrocartilage, the medial side is more likely to be injured. There's more force going to the medial side, but the medial meniscus is also attached to the capsule, and it's attached to a ligament, the MCL, and there's not a lot of movement there, even though there's a lot of force. So go back to my module and watch that video that explains that, but the medial meniscus is the one that is most likely to be injured. All right. And so when we're talking about the knee in general and high injury spots, so I talked about the medial knee, right? So, we're going to go here on this medial side over here, actually. What we worry about on the medial side is the medial meniscus. Like I said, there's a lot of energy. So anytime we're running and we rotate, right? So we like spin fast. So we change directions really fast. What we worry about is this kind of movement, and the medial meniscus isn't moving, so we tear our meniscus. But in a child, our cartilage, the ends of our bones are really soft. We can get osteochondral defects. I tell a little story about a squash player that looked like a medial meniscus, and it was not. So make sure you go back if you aren't watching my videos and watch that, because that is going to come up on the exam. So osteochondral defect is when the cartilage pulls off, and yes, can a meniscus tear happen in a child? Yes. Can an osteochondral defect happen in an adult? Yes. But it's more likely to be meniscus in an adult because the bone is strong and the meniscus is going to bend under pressure and tear. Where in a child, that osteochondral defect, that cartilage is likely going to pull out because it's nice, soft, and squishy. All right, what else we're talking about when we're talking about those knee types of injuries? We have our ACL and PCL. Just know that when we're talking about those ligaments and the what it's protecting against. So we have our MCL that's protecting against varus strength, so on the medial side. So if someone gets hit on the outside, the medial side caves. That's the MCL, and that's valgus stress. The LCL is varus stress, and you get hit on the inside and puts that pressure on the outside. Remember, ACL is preventing anterior translation of the, so anterior cruciate ligament, anterior translation, posterior cruciate ligament, posterior translation of the tibia. And that's what those are preventing. And then I also want to bring your attention to those Sargent muscles at the pes anserine bursa. It's sartorius, gracilis, and semitendinosus. That T in tendinosus is the T in Sargent. SGT is abbreviation for Sargent. So Sargent muscles attached to the medial tibia, near the tibial plateau. It's attachment point, and those muscles cross the knee and the hip. So when people get medial knee pain after they're doing things where the knee and the hip are bending a lot, so that's like climbing stairs, doing hills, doing bicycling. So like if a swimmer's like, I'm cross training now and I decided to go climb stairs and do hills, and I'm bicycling up hills, and they're having medial knee pain, you should always check pes anserine bursitis, because there's a bursa there where all three of those tendons are attaching on one spot. So it's a high frequent area for injury. So it's important to understand that spot. And then just in general, when we talk about the force through the knee, so when the knee is extended and we're in a weight bearing position, that force, like I talked about, is going through the medial knee. and it's going through the medial tibial plateau, is taking a lot of that force. Soon as we bend the knee, you also have this kneecap that's out here too. When we get to 60 to 90 degrees of flexion, of knee flexion, that's where we have the highest point of stress through the patellofemoral joint. That's where the kneecap is sitting on the knee. So it's important to understand when we're in weight bearing, that's how that force is distributed. And those are the areas that we really need to be looking at. All right, we are going to move on to hip. So hip bony anatomy is very simple. You're looking at the acetabulum, the femoral head, and the femoral neck. The femoral neck is that little stretch of bone that's between the femoral head and the femur. So make sure you go back to my modules, watch my videos. I have it more clearly labeled on there, but make sure you understand that. And then your trochanter is that lateral area on that femur that sticks out a little bit, and that's where we get trochanteric bursitis that we will talk about with those muscles rubbing over it. When we talk about the muscles of the hip, the most important thing to really understand is that we have our hip flexors on the anterior side that are going to flex our hip, pull it up. Those are our psoas, or our main ones. Our quad muscles also contribute to this. They predominantly do our knee extension, but they also do our hip flexion. On the back side, the posterior side of our hip, we have our hamstrings, and we have our glute muscles that are helping extend our hip back. And then our abductors, our glute medius is predominantly, and we have some other muscles that also help, but our glute medius, abducts, and our adductors, ADD, is adding to the body, and it's pulling the leg toward the body. Those are our adductor muscles, and our gracilis muscles as well. So then when we talk about how all of this contributes to injury in general, first let's just start with the trochanteric bursitis that we talked about. So when you're looking at this image with the muscles here, you see the tensor fascia lata. So it is a piece of fascia that is attached to the muscle that leads down into the IT band, and it goes from the hip all the way to the pelvis, the ilium, all the way down to the tibia, and it's crossing the hip and the knee. So we talked about how all the muscles that do that, they have a lot of problems, right? Because they're crossing two joints, they're bending and moving all of the time, and a lot of overuse, chronic type of injuries. But when we talk about a fascia that doesn't have much elasticity, it gets really tight and causes a lot of pain. So that's where we get IT band syndrome in the knee on the lateral side. And then we also get trochanteric bursitis, where it's rubbing over that trochanter that's kind of sticking out on the hip, and that the glute muscles and the TFL is rubbing on there, and it creates that bursa that's sitting there to get inflamed and angry. So whenever someone's doing a lot of hill running in general, but like hills, biking, things where they're moving their hip and their knee a lot, and they report butt type pain or hip pain, it's usually trochanteric bursitis. Now, the other hip injury that's more serious that we worry about is our labrum. So also consider the amount of force going through the hip. So it's weight bearing. So our whole body weight is going through when we are in weight bearing position. The most weight possible, the most force possible is when we are running, because we're only on one leg at a time, and there's as much force as possible. We can have up to 10 times our body weight while we are running on a single leg going through that hip joint alone. So when we look at our labrum, labrum is what lines the acetabulum, and our femoral head shape has a big part in where that injury. So that's called femoral acetabular impingement. So you look at this picture over here. A is looking, there's two ways you can have femoral acetabular impingement, a cam lesion or a pincer lesion. So A is a cam lesion, and that is when the femoral head is longer than it should be. So when it moves in the acetabulum, it's getting pinched where that labrum is coming out, those little triangles there that you see. And then on C, you have your pincer lesion. Think of a crab pinchers, pincer, pincher. So it's like pinching the femoral head and not allowing much movement. So when we look at when someone has a pincer or a cam lesion on x-ray, they are more likely to have a labrum tear, they're more likely to have pinching, and they're probably more likely to be a man, because it's more common in men to have those FAI, femoral acetabular impingement, and which leads to labrum tears, and labrum tears can cause a lot of pain and sometimes leads to surgery. So I know these are quick explanations, so if it's not quite clicking with you, that is a signal you need to go back to the module and watch that original video. So hopefully these questions were helpful to you to test and know where you are. If you have any other questions, look back in the modules, and if that isn't helpful, reach out to me. Good luck.